Swayam Prabha. Digital India. Educated India.
Hello everyone. This is a session on development of hindgut. I am Dr. Deepthi Shastri, Deputy Dean, Professor of Anatomy at Vinayaka Mission's Kripananda Varya Medical College and Hospitals, and Dean, Faculty of Medicine at Vinayaka Mission's Research Foundation, deemed to be University, Salem, Tamil Nadu. And I'll be your instructor for this session. We'll begin this session with a clinical vignette of the case of a newborn child who doesn't pass stools for 2 days after birth. The diagnosis made after clinical examination is that of imperforate anus. And we need to explain the embryological basis of this condition. Here is another case of a newborn child with a watery secretion from the umbilicus, which is termed as weeping umbilicus. A diagnosis after clinical examination is made of urachal fistula, and we need to explain the embryological basis of this condition. In order to be able to explain the embryological basis of such clinical conditions, we need to know the development of hindgut. The objectives of this session are, by the end of the session, you will be able to mention the subdivisions of hindgut, describe the derivatives of hindgut, explain the congenital anomalies of hindgut. In addition to that, you will be able to describe the location of urechus, mention the derivative of urechus, and explain the congenital anomalies of urechus. Let me begin with a brief introduction. The part of the primitive gut tube which is caudal to the communication with the definitive yolk sac is the hindgut. In this illustration, you can see the hindgut. This is the connecting stalk which later develops into the umbilical cord. The vitalointestinal duct passes through the connecting stalk and connects the primitive gut tube to the yolk sac. So, the part of the gut tube that is caudal to this communication is called as the hindgut. The hindgut, which is derived from endoderm, is separated from proctoderm, which is derived from ectoderm, by the cloacal membrane. The cloacal membrane is derived from endoderm of the hindgut and the ectoderm of the proctoderm, with no intervening mesoderm. At a later stage of development, the cloacal membrane is split into two membranes, urogenital membrane and anal membrane, and these two membranes rupture. When the anal membrane ruptures, the gut tube opens to the exterior. Now let us look at the blood supply of the hindgut. The artery of hindgut is inferior mesenteric artery. It supplies all the structures that are derived from the hindgut. Inferior mesenteric artery itself is a branch of dorsal aorta. Dorsal aorta gives rise to the celiac artery, which supplies the derivatives of foregut, superior mesenteric artery, which supplies the derivative of midgut, and inferior mesenteric artery, which is the artery of hindgut and supplies all the structures derived from the hindgut. Now let us look at what these derivatives of hindgut are. The derivatives are the left 1/3 of transverse colon, descending colon, sigmoid colon, rectum. All these are present on the left half of the abdominal cavity. The left 1/3 of transverse colon, descending colon, sigmoid colon, rectum. The other derivatives are the upper 2/3 of anal canal, which lies in the pelvic cavity, and parts of urinary system, which again lie in the pelvic cavity. Let us look at this illustration of hindgut to understand how the hindgut is subdivided. This is the hindgut as we have seen earlier. The terminal expanded part of the hindgut is called as the cloaca after it receives the allantoic diverticulum. The allantoic diverticulum is developed when the embryo is in the germ disc stage. Allantoic diverticulum develops from the roof of the yolk sac from the caudal end of the germ disc and extends into the connecting stalk, which later forms umbilical cord. So this is the allantoic diverticulum, which gets absorbed into the gut tube when the tail fold of embryo is developed. So the hindgut is the part of the gut tube distal to the connection with the yolk sac. The part of gut tube which extends to the terminal end after it receives the allantoic diverticulum is termed as the cloaca. At this stage, the mesoderm which surrounds the developing hindgut becomes condensed to form the urorectal septum. The urorectal septum extends in the angle between the allantoic diverticulum and the hindgut and divides the cloaca into a ventral broad primitive urogenital sinus and a narrow dorsal primitive rectum. The urorectal septum descends down from the hindgut to the cloacal membrane, and it separates the cloacal membrane into a ventral urogenital membrane which lies below the urogenital sinus and the dorsal anal membrane which lies below the primitive rectum. To reiterate what I have just said, before the formation of tail fold in the embryonic disc, an endodermal diverticulum from the yolk sac at the caudal end of the germ disc or embryonic disc extends into the connecting stalk and is called as allantoic diverticulum or the urechus. After the formation of the tail fold, part of this diverticulum is absorbed into the hindgut. The part of the hindgut which is caudal to the attachment of allantoic diverticulum, that is the terminal expanded part of gut tube, is called as the cloaca. The cloaca is divided by the mesodermal condensation which extends in the angle between allantoic diverticulum and hindgut and is called as urorectal septum. It divides the cloaca into a broad ventral primitive urogenital sinus which forms the lining of the urinary bladder and urethra, and a narrow dorsal primitive rectum which forms the rectum and upper 2/3 of anal canal. The urorectal septum extends up to the cloacal membrane and divides it into a ventral urogenital membrane and a dorsal anal membrane. The area of fusion of urorectal septum with the cloacal membrane is represented in the adult as the perineal body. At this stage of development, the mesoderm around the anal membrane proliferates and it produces elevations in the surface ectoderm. Because of these surface elevations, the anal membrane comes to lie in a depression which is lined by ectoderm and is called as anal pit, also called as proctodeum. The proctodeum contributes to the formation of lower one-third of anal canal. We have seen earlier that the upper two-thirds of anal canal is developed from the endoderm of the primitive rectum. The lower one-third of anal canal is developed from the ectoderm of the proctodeum. To summarize what we have learnt so far, hindgut is the caudal part of primitive gut tube. The allantoic diverticulum, an extension from the roof of yolk sac, opens into it. Cloaca is the part of the hindgut which is beyond the allantoic diverticulum. The artery of the hindgut is inferior mesenteric artery, which is a branch of dorsal aorta, and it supplies all the derivatives of hindgut. The derivatives of hindgut are the left one-third of transverse colon, descending colon, sigmoid colon, rectum, upper two-third of anal canal, and parts of urinary system, that is urinary bladder and urethra. The cloaca is divided by urorectal septum into primitive urogenital sinus ventrally and primitive rectum dorsally. The urorectal septum extends and divides the cloacal membrane into a urogenital membrane ventrally and anal membrane dorsally. We are done with subdivisions of hindgut. Now let us look at the derivatives of hindgut. The first derivative is the left one-third of transverse colon. The right two-thirds of transverse colon, however, is derived from the midgut. The dual origin of transverse colon is reflected in its arterial supply. The right two-thirds of the transverse colon is supplied by the artery of midgut because it develops from the midgut, and the artery is superior mesenteric artery. While the left one-third of transverse colon is derived from hindgut and is supplied by the artery of hindgut, that is inferior mesenteric artery. The second derivative of hindgut is the descending colon. Unlike the transverse colon, which has a mesentery called as mesocolon, transverse mesocolon, which contains superior mesenteric artery, the descending colon is retroperitoneal. It becomes retroperitoneal after the rotation of the gut by the fusion of its mesentery with the parietal peritoneum lining the posterior abdominal wall. The third derivative of hindgut is the sigmoid colon. It is derived from the primitive rectum and retains its mesentery called as sigmoid mesocolon. The fourth derivative is rectum, which is derived from the primitive rectum. Primitive rectum gives rise to rectum, which also becomes retroperitoneal after rotation of the gut due to fusion of its mesentery with the parietal peritoneum of the posterior abdominal wall. The next derivative is anal canal. The upper two-thirds of anal canal is formed from the endoderm of the primitive rectum, while the lower one-third of anal canal is formed from the ectoderm of proctodeum. The junction between the two sources of origin of anal canal is represented by the pectinate line at the anal valves. The lining epithelium, blood supply, lymphatic drainage and nerve supply of anal canal differ above and below this watershed line, the term used for pectinate line. Above the pectinate line, the lining epithelium of anal canal is simple columnar epithelium, while below the pectinate line, it is by stratified squamous non-keratinized epithelium. Simple columnar epithelium is similar to the rest of the transverse colon derived from the endoderm of the gut tube, while the lower one-third of anal canal receives the stratified squamous non-keratinized epithelium similar to the structures derived from ectoderm because it is derived from proctodium. Blood supply of anal canal above the pectinate line is by superior rectal artery, which is a branch of inferior rectal artery, the artery of Hindgut. While the part of anal canal below the pectinate line is supplied by a branch of internal pudendal artery called as inferior rectal artery. Venous drainage similarly above pectinate line is by superior rectal vein, which drains into inferior mesenteric vein, which drains into portal vein. While below the pectinate line, it is drained by inferior rectal vein, which drains into internal pudendal vein and internal iliac vein. Lymphatic drainage of anal canal above the pectinate line is into sacral and abdominal lymph nodes, while below the pectinate line, it is into superficial inguinal lymph nodes. The nerve supply of anal canal above the pectinate line is similar to other visceral organs by autonomic nervous system by the pelvic splanchnic nerves, while below the pectinate line, anal canal is supplied by branches of pudendal nerve. So, this is how the two sources of origin of anal canal are represented above and below the watershed line. Now, moving on to the derivatives of allantoic diverticulum. The proximal part of allantoic diverticulum forms the apex of urinary bladder. The distal part of allantoic diverticulum, however, degenerates and it gives rise to the median umbilical ligament, which is seen in the posterior part of the anterior abdominal wall. The urogenital sinus forms epithelial lining of urinary bladder and urethra. The urogenital membrane at the lower end of urogenital sinus and anal membrane at the lower end of primitive rectum rupture at the end of 7th week of development, so that the urogenital system and the anal canal open to the exterior. We are done with the development of hindgut. Now let us look at the congenital anomalies of hindgut. The main congenital anomaly is fistula involving the rectum, which occurs due to incomplete partition of the cloaca by the urorectal septum. Abnormal communications hence occur between the rectum and the urinary bladder, which is called as rectovesical fistula, or abnormal communication can occur between the rectum and urethra, which is called as rectourethral fistula. This is a sagittal section of male pelvis showing urinary bladder and urethra anteriorly and the rectum posteriorly. Now let us look at other congenital anomalies due to failure of complete partition of cloaca by the urogenital septum or urorectal septum. This is a sagittal section of the female pelvis showing the uterus and vagina between urinary bladder anteriorly and rectum posteriorly. And here a fistula can occur where there is abnormal communication of rectum with the vagina. This is called as recto-vaginal fistula. Next, we move on to another congenital anomaly of the hindgut, which occurs at the lower end of the primitive rectum, called as imperforate anus. Imperforate anus is when the anal canal does not open to the exterior and may be caused by stenosis of the anal canal or a persistent anal membrane. That is, the anal membrane fails to rupture. Next, we move on to congenital anomalies of the urechus. Now, this is a normal condition where you find the urinary bladder, and this is the degenerated urechus forming the median umbilical ligament. These are all illustrations showing congenital anomalies of urechus. Urachal fistula occurs when there is patent urechus or patent allantoic diverticulum. Here, the urechus is connected to the urinary bladder at the proximal end and to the umbilicus at the distal end. Because the urachal fistula is connected to urinary bladder, urine dribbles through this urachal fistula at the umbilicus. This is the term used for weeping umbilicus. That is, secretion or a watery secretion which is actually urine dribbling at the umbilicus is called as weeping umbilicus. Here is another congenital anomaly of urechus where the proximal and distal parts of urechus are degenerated, but the part of urechus in between remains patent and is filled with fluid. This is called as urachal cyst. Here are two other congenital anomalies of urechus. Urachal sinus occurs when the distal part of the allantoic diverticulum remains patent and opens towards the umbilicus. Urachal diverticulum appears like an outpouching of the urinary bladder. It occurs when the proximal part of the urechus remains patent. We are done with the development of hindgut. Now let us discuss the clinical vignettes I started out with. So first is a case of a newborn child who doesn't pass stools for 2 days after birth. After clinical examination, a diagnosis of imperforate anus was made. And with your knowledge of embryology of hindgut, you need to explain the embryological basis of this clinical condition. And the answer is imperforate anus occurs due to failure of rupture of anal membrane or due to stenosis of anal canal, due to which the anal canal does not open to the exterior. Now let us look at the second case. This is a case of a newborn child with a watery secretion from the umbilicus, which is termed as weeping umbilicus. After clinical examination, a diagnosis of urachal fistula has been made. And with your knowledge of embryology, you need to explain the embryological basis of this condition. And the answer is urachal fistula occurs due to the failure of degeneration of urechus or the presence of a patent urechus. Normally, the urechus degenerates to form the median umbilical ligament. The proximal part is absorbed to form the apex of urinary bladder. If the distal part of urechus is not degenerated, it remains patent, causing urachal fistula. The hindgut is the caudal part of primitive gut tube. Allantoic diverticulum opens into it. After the entry of allantoic diverticulum, which is actually an extension from the roof of yolk sac from the caudal end of germ disc into the connecting stalk, which later forms the umbilical cord, after this allantoic diverticulum opens into the hindgut, the terminal part of hindgut which is dilated or expanded is called as cloaca. So, cloaca is the part of hindgut which lies beyond the allantoic diverticulum. The artery of hindgut is inferior mesenteric artery. It is a branch of dorsal aorta. Dorsal aorta gives rise to branches to the foregut, which is celiac trunk, midgut, superior mesenteric artery, and the artery of hindgut, that is inferior mesenteric artery. Inferior mesenteric artery supplies all the derivatives of hindgut. The derivatives of hindgut are the left 1/3 of transverse colon, descending colon, sigmoid colon, rectum, upper 2/3 of anal canal, and parts of urinary system, that is lining epithelium of the urinary bladder and urethra. The right 2/3 of transverse colon develops from midgut, while the left 1/3 of transverse colon is derived from hindgut. You also need to note that the upper 2/3 of anal canal develops from the primitive rectum part of hindgut, while the lower 1/3 of anal canal develops from the ectoderm of the proctodeum. The congenital anomalies of hindgut are imperforate anus, which occurs due to failure of rupture of the anal membrane or due to stenosis of the anal canal. The other congenital anomalies are rectovesical fistula, rectourethral fistula, rectovaginal fistula, where the rectum communicates with the urinary bladder, urethra or vagina in females. And this occurs when the urorectal septum fails to partition the hindgut and cloaca completely. The congenital anomalies associated with the urechus are urachal fistula, urachal sinus, and urachal cyst. These congenital anomalies occur due to failure of degeneration of urechus. Normally, urechus distal part degenerates to form the median umbilical ligament. Only a small part of the proximal part of urechus is absorbed into the urinary bladder to form its apex. When the urechus fails to degenerate, it remains patent to form urachal fistula, urachal sinus or urachal cyst. That brings us to the end of this session on development of hindgut. Now let us look at some review questions in the form of multiple choice question. You may think up the answer as I read out the questions. The first question is, the following is a derivative of hindgut, and the options are A. Appendix, B. Meckel's diverticulum, C. Apex of urinary bladder, and D. Gallbladder. And the response to this question is C. Apex of urinary bladder. Appendix and Meckel's diverticulum are derived from midgut, while gallbladder develops at the junction between foregut and midgut. The answer to derivative of hindgut is hence the apex of urinary bladder. It develops from the proximal part of urechus. We now move on to the second question. The following artery supplies the derivatives of hindgut, and the options are A. Dorsal aorta, B. Celiac trunk, C. Superior mesenteric artery, D. Inferior mesenteric artery. And the answer is D. Inferior mesenteric artery. The dorsal aorta gives celiac trunk, superior mesenteric artery and inferior mesenteric artery. Celiac trunk is the artery of foregut and supplies all the derivatives of foregut. Superior mesenteric artery is the artery of midgut. It supplies all the derivatives of midgut. So, the answer to this question, the derivatives of hindgut are supplied by inferior mesenteric artery. Now, we move on to the third question, and that is, urachal fistula develops from A. Allantoic diverticulum, B. vitellointestinal duct, C. thyroglossal duct, and D. cervical sinus. And the answer to this question is A. Allantoic diverticulum. Vitellointestinal duct connects the midgut with the yolk sac, and the congenital anomaly that is related to vitellointestinal duct is vitellointestinal fistula. The thyroglossal duct arises from the tongue, dorsum of the tongue, in the center of the junction between anterior 2/3 and posterior 1/3 of the tongue, and it gives rise to the thyroid gland. After forming thyroid gland, thyroglossal duct disintegrates and disappears, but if it remains behind, it forms the thyroglossal fistula and it lies in the neck. Cervical sinus is in the neck. It is related to the second, third and fourth ectodermal clefts during development of branchial or pharyngeal apparatus. Normally, it is obliterated to form the skin of the neck. If the cervical sinus is not obliterated, it forms branchial fistula, which also lies in the neck. So, the answer to this question, urachal fistula develops from, is allantoic diverticulum. Normally, it is degenerated to form median umbilical ligament. If the allantoic diverticulum does not degenerate, the patent allantoic diverticulum forms urachal fistula. Next, we move on to the fourth question. The lower part of anal canal develops from, and the options are A. Neural crest, B. ectoderm, C. mesoderm, and D. endoderm. And the answer to this question is B. ectoderm. The lower one-third of anal canal develops from ectoderm of proctodeum, while the upper two-thirds of anal canal develops from endoderm of the primitive rectum. That brings us to the last question of this session. Remnants of urechus form A. Median umbilical ligament, B. Medial umbilical ligaments, C. Lateral umbilical folds, and D. Round ligament. And the answer to this question is A. Median umbilical ligament. All these options lie in the posterior part of the anterior abdominal wall. Medial umbilical ligaments are formed from degenerated umbilical arteries. Lateral umbilical folds are actually folds of peritoneum over the inferior epigastric arteries, while the round ligament of uterus is a remnant of gubernaculum. So the correct answer to this question, remnants of urechus form, is median umbilical ligament. Urechus distal part generally degenerates to form median umbilical ligament, while the proximal part is absorbed to form the apex of urinary bladder. And that brings us to the end of the topic. Thank you.